Good afternoon, everybody, and welcome to this Parkinson's Academy webinar on the subject of advanced care planning in Parkinson's. Delighted to be joined by Dr. Tim Jackson and Dr. Ed Richfield this Wednesday afternoon to talk about this subject. Before I get Tim to open the proceedings, a huge thank you to our sponsors, Profile. Without them, we wouldn't be able to put these webinars on. And as over 200 of you have joined the webinar, I think it's probably a topic that people really want to understand more about. So without any further ado, I will ask Tim to start the proceedings. Just to remind people, can you use the Q&A function for any questions? And we will be taking those questions at the end of Tim's presentation. So thank you very much, everybody. And over to you, Tim.
Great. So I'm Tim Jackson. I'm a palliative medicine consultant in Salford. I've been a consultant here for the last 6 years, and I've got a special interest in neurological conditions. And I guess that started as a registrar, and I've done various things here at Salford, which is a neurocentre. And one of those things has been clinic outreach into patients with motor neuron disease, but we've also recently started doing clinic outreach for palliative care for patients with atypical Parkinson's. And that's a relatively new clinic, but I think it's really highlighted the importance of key points of disease progression, identifying advancing disease in patients with Parkinson's disease, and really advanced care planning. I think the whole clinic focus is really advanced care planning a lot more than it is around some of the other disease groups that we see in palliative care. I'm conscious that many of you have a background in working with people with Parkinson's disease in either neurology or many geriatricians on the call as well. So I'm just giving my experience here. I understand that a lot of you will have experience in this area. I'm very happy to take points at the end and share experience. So in terms of objectives, so we'll talk a bit about the advanced care planning in general. We'll talk about some of the specific evidence for advanced care planning, both more generally and in Parkinson's disease. We'll talk about practical tips, nuts and bolts on how we would approach advanced care planning, or how we might approach advanced care planning, and some of the points that I use in my own practice around that. We'll also talk about some of the specific tools that you can talk about, that you can use in advanced care planning in relation to things like advanced decisions, advanced directives, and lasting power of attorney. And as I said, a lot of this is common to all disease groups, but particularly we'll talk about neurological conditions and Parkinson's disease and specific relevant considerations. So I've tried to pitch this for a wide audience. So I appreciate that lots of you will have lots of advanced care planning experience, but we'll start with the basics. So in terms of definitions of advanced care planning, I thought this was quite a good one. This is a nice definition from 2019. So advanced care planning offers people the opportunity to plan their future care and support, including but not limited to their medical treatment, whilst they have the capacity to do so. Clearly, not everybody will want to do that, and it has to be done at the right time for them. And it should be particularly focused on patients with a life-limiting condition, patients who may lose their mental capacity for any reason, or patients whose mental capacity might vary at any one time. And I think that's quite a nice quote at the end, that advanced care planning makes the difference between a future where someone can make their own decisions and a future where they're unable to do so, where others do. This is another kind of international consensus definition of advanced care planning. So a process that supports adults at any age, any stage of their health in understanding and sharing their personal values, their life goals, and their preferences regarding future medical care. So again, not focusing just on the medical side of things. The goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. So I guess I wanted to think about kind of our own thoughts about advanced care planning and experiences. There is the Dying Matters group and the Dying Matters week that we have every year, which really promotes advanced care planning and thinking about the future for everybody, not just someone with life-limiting conditions. But I thought it might be useful to just think for a moment about how you feel about talking to patients about death, about dying, but not just about end of life, about their more general advanced care planning wishes. Because I suppose as a palliative care consultant, I do that a lot, and I'm relatively comfortable with it most of the time, but there still is occasions where it's challenging and difficult. And perhaps if you find those episodes challenging and difficult at times as well, think about what it is that you feel makes that difficult at times. And then how do you feel about talking about death and dying with people close to you? It's not necessarily something that we do regularly. I think in Britain, it's something that we're not necessarily very good at being very open about. And perhaps also, what have you considered about your wishes towards the end of life? Not thinking necessarily about specific medical elements, although it could be your more general wishes. I know, working in palliative care, that's something that probably comes to the fore more than most for me, but still, I've never really written anything down, and perhaps applies and don't have a will at the moment. It's probably something I should get sorted. In terms of the things that we might include in advanced care planning, this is from the NHS guide for health and care staff about kind of general areas you might consider. So it can include personal wishes, general priorities, your concerns about your future care in any element. It might be around specific goals for care and treatment. So that goal to remain in your own home may be the most important overriding thing, for example, for a patient. There may be key points to consider related to a specific disease process. So I suppose thinking about things like motor neurone disease, where you would think about the need for consideration of a tube feeding or respiratory support, ventilatory support. It might focus around refusal of specific investigations or treatments. It may be a more general statement about your values and not talk about specifics at all. And then there are the end-of-life considerations, which I think, we can conflate advanced care planning with just the end-of-life considerations sometimes, preferred place of death, getting that down on paper. And that is certainly not my idea of good advanced care planning. It's more than just preferred place of death. Kind of moving on from that, really, this was just to illustrate, the point around it not just being about your specific medical considerations and need. This is Stephen Sutton, who you may be familiar with. He's a gentleman who sadly died quite young, at the age of 20, as a result of bowel cancer. But when Stephen got his diagnosis of metastatic disease, he started that kind of wider process of advanced care planning, not necessarily all about the specifics of his disease, but what he wanted to really get out of his life and what he felt was important to fulfill his life. And some of that was around starting a blog, which he wrote for some time. And he set a target of trying to raise £10,000. Within a year, he'd raised £500,000 and he'd essentially gone viral, become a lot more famous. And so it is bucket list. So this was just to illustrate some of the other wider points, because I think, advanced care planning is all about quality of life. It's all about what's important to the person themselves, not just around those medically driven targets around medical treatments, admissions, hospitalisation. So these are just some of the things. I hope that's coming up okay on your screen. So his target was raise 10,000 for a teenage cancer trust. I said he raised 500,000 in his first year. That smashed to £1 million, and actually within 2 years of his death, he'd raised over £5.5 million. Charity skydive, writing a book, meeting with various famous people, going to music festivals, having a song written about him. So, all sorts of wider elements rather than just the perhaps nuts and bolts and more medicalised advanced care planning that we would consider. So what do we know about advanced care planning in general? We know, as I said, that we don't do it particularly well in Britain. Around about a third of us have written a will. Around about a third of us have registered as an organ donor. I know some processes have changed around that recently, but still small numbers. Less than a third have let someone know about the funeral wishes. But when we come to the specifics of actually writing something down about wishes around the future, preferences and future care, only around 6% of people have done that. We know that of people who do express a preference, often people would prefer, when we're talking about end of life, to end their life in their own home. So generally the figures are at somewhere around 80%. If you ask a well population where they would like to die, they will generally say in their own home environment. But actually that's not what happens for a lot of people, as I'm sure you're familiar with. Only about half of people in this survey, so this was from the National Voices survey, who wanted to die at home, actually died in their own home. About a third of people who wanted to die at home died in hospital. These are the actual place of death figures for England and Wales for 2019, so around 531,000 deaths. You can still see that the most common place of death is in hospital, over 40%. Home and care home being the other common places, and hospice being less than 10%. So I suppose in specialist palliative care, we often think about hospice being that kind of gold standard of specialist palliative care, but actually it's open to relatively few patients. And the trend is changing with that, and has changed over recent years. If we look back over the last decade, for example, that number has come down in terms of hospital deaths, from around 55% to nearer kind of 45%, but still the significant, well, not the majority, but the most common place of death, it remains hospital. And then if we look at different conditions, we know that, for example, people with cancer are more likely to be able to die in their own home, meet those wishes, whereas people with neurological conditions are less likely to do so and more likely to die in hospital. So this data looked at all kind of neurological conditions classified from MND, MS, Parkinsonism, also included traumatic brain injury, nervous system tumours, so some crossover with the cancer group. And I think that probably is, at least somewhat to do with advanced care planning, because I think, that cancer disease group where we know there is more of a predictable trajectory, perhaps we might be more willing and more comfortable with doing the advanced care planning, the processes are there, whereas patients with neurological conditions, particularly kind of more chronic neurological conditions, it's not always as easily done or as usual part of their treatment and planning. In terms of that focus around place of death, does it actually make a difference? Well, this is also from the Voices Bereavement Survey, and this looks at a rating of quality of care by where people died for several thousand people. Major caveat on this is this obviously is from the relative or care of the friend of the person that's died. So does it make a difference? Well, actually, it's heartening to see that, in each of those settings, the majority of people rated their loved one's care as outstanding, excellent, or good, but still significant room for improvement, particularly in that hospital setting compared to, the hospice or care home setting where far higher numbers were rated as outstanding or excellent, and there were far fewer fair or poor. And then in terms of whether people died in the right place from the same survey, a significantly lower number of patients felt to have died in the right place by their loved ones when they died in hospital, whereas there's more planned deaths perhaps in the hospice or home setting. People generally felt more comfortable that their relatives had died in the right place. So looking at the evidence then around advanced care planning, particularly in Parkinson's disease, I had to look at the most kind of recent studies that have come out, and this was one study that I just wanted to look at. This was a study that looked at engagement with advanced care planning and views in advanced care planning of patients in carers. It was a mixed method survey questionnaire of about 100 patients and then semi-structured interviews. And whilst most of the patients were not aware of the specific term of advanced care planning, many of them had actually undertaken some form of planning. So, for example, around a quarter had a lasting power of attorney for health and welfare. And even where people hadn't undertaken advanced care planning, they were actually quite interested when offered in finding more about advanced care planning. People in general seem to have quite poor understanding of some of the specific tools, so particularly things like advanced decisions to refuse treatment. And people were absolutely keen to involve family health professionals in this process to help guide that. Interestingly, a lot of the people that they surveyed, regardless of what stage of disease that they were at, didn't feel that then was the right time to do advanced care planning, and they wanted to leave it for the future. Whereas when they asked the relatives, actually they felt that it was absolutely the right time to start looking at things now. So I guess that's again some of the comfort with advanced care planning, and perhaps relates to how we introduce things. This was another study, so this was a systematic review looking at 27 studies, so a mixture of qualitative and quantitative studies on advanced care planning in Parkinson's disease. So they found that the commonest areas of discussion were around end-of-life care wishes, CPR decision-making, nutrition, hydration, goals of care, ceiling of treatment, and things like lasting power of attorney. But where advanced care planning did take place, unfortunately, it was not often well communicated, even when it was done well. There was quite a diverse opinion on when advanced care planning should take place. And of the patients and service studies that they looked at, a number of them suggested that could be done earlier in atypical diseases you might expect with that shorter prognosis. Patients themselves in some of the studies seem to suggest that advanced care planning was often prompted by them rather than by healthcare professionals. And again, as you might expect, it was often prompted by crises and things like hospital admission. And then this was a piece of work that I did actually a few years ago as a registrar, where I did some interviews with health professionals looking at their understanding of and views on advanced care planning in Parkinson's disease. And in terms of what they were doing in their own practice, many of them felt that advanced care planning wasn't consistently taking place, that when it did take place, it took place late in disease, that it was often very variable depending on which team was involved or taking the lead with the care of the patients with Parkinson's disease. And whilst there were lots of tools there wasn't a specific kind of consistent approach to using those. And in terms of why people felt that the level of advanced care planning wasn't consistent, I think there was agreement that the prognosis and disease course being more difficult to predict than some of the certain disease groups we see in palliative care was probably one factor. Then there was the professional confidence. They may not feel confident in initiating advanced care planning discussions. They may not have had specific training around that. There's the patient factors, so they may not want to have those discussions. There's the time-old issue in the NHS of not having enough time in busy clinics. And then some people felt that there wasn't specific resource to guide exactly what we should be discussing as part of advanced care planning in Parkinson's disease. There was also the issue raised around cognitive impairment in patients with Parkinson's and the potential impact of that. So in terms of then coming back to when we should do advanced care planning, I think it's really variable, and certainly in my practice, I'm basically happy to do it at any point that someone has a diagnosis of a life-limiting condition. But as we've seen from the kind of Dying Matters promotion, it doesn't even have to be then. You can do elements of advanced care planning before that. And interested in your thoughts of people on the call about that as well. So should it be at any time after diagnosis? I think, at diagnosis is often quite a difficult time and perhaps isn't necessarily the right time. But if patients raise that, then perhaps it can be. Do we focus it more towards the last year of life? Do we focus it more within that last year towards advancing disease when we're seeing signs of repeated hospital admissions? Those are the cues that we can look at. Do we look at it when patients request it at any time? Do we focus it in relation to when we're having wider discussions about the future, about symptom control in response to patient cues? Do we use specific disease-specific parameters to guide us? And I think, basically it could be all or any of those. We've got the kind of different suggested phases of Parkinson's disease. And whereas perhaps it's been traditionally more in the palliative phase that we've looked at advanced care planning, I think, potentially it could go across all of those phases, that we could offer different elements of advanced care planning tailored to what the patient wants and what they feel comfortable with. If we're looking at specific guidance, a lot of you may be familiar with this already. So there are guides for what we should be looking at in patients with lots of different health conditions. This is from the gold standards framework, prognostic indicator guidance. So one of their first questions is, would you be surprised if this patient died in the next 12 months? If the answer is no, then absolutely look at elements of advanced care planning that the patient wants to undertake. And there are disease-specific elements related to Parkinson's disease. So those are when the drug treatments are becoming less effective, where there's an increasingly complex drug treatment regime, where the patients have reduced independence, where the control of their disease is fluctuating a lot more with on-off periods, where they're having recurrent falls, worsening mobility, where they're starting to develop more prominent psychiatric signs, or where there is just generally increasing frailty. And there are specific frailty markers within that gold standards framework guidance as well. So this is available freely online. If you Google gold standard framework prognostic indicated guidance, if you're not familiar with this, it's really worth looking at from a general advanced care planning point of view, but also with regard to those specific points in Parkinson's disease, the specific points around things like motor neuron disease as well, other non-malignant conditions. In terms of thinking about when, I guess the other thing in Parkinson's disease to consider is the cognitive impairment issues. We know that it is a factor in Parkinson's disease and atypical Parkinson's disease, that at some point up to 80% of people will have some form of cognitive impairment. The prevalence within Parkinsonism is somewhere around 40% with some level of cognitive impairment. And obviously we've got those patients with dementia with Lewy bodies where that may be a more prominent feature at an earlier stage. So in summary, in terms of when, I would be happy to do it any stage. You may be looking for those disease-specific cues, and it's worth having an awareness of those if you haven't already. So moving on to who should be involved. So again, there isn't any specific clear guidance around this. It could involve the person. Some people want to do that alone. Some people want to do it in conjunction with others. Some people do want to involve their relatives, whereas obviously clearly that's quite a diverse area depending on what relationships are like within the family or with friends. Lots of people do want to involve health professionals, and I think actually it's quite important when you're getting down to the specifics of things like advanced decisions to involve a healthcare professional who will be able to go through the experience of using those. I think it can be any health professional with the right experience who feels confident and competent to have those discussions. It doesn't need to be a palliative care consultant. It doesn't need to be a clinical nurse specialist in palliative care. It doesn't need to be someone with experience in that condition necessarily, as long as they feel that they have the right experience to answer the patient's questions and to support them in that role and to refer to the right people and the right information if there's something they can't answer. In terms of setting, I think that's, we know it often happens in response to cues when people are admitted to hospital. It's not the ideal setting to be doing in a hospital situation where people are perhaps behind a curtain in a noisy environment, feeling tired, not getting much sleep. But then it's also difficult in the clinic setting where patients may be allocated, 10, 15 minutes or a very short period of time to get through their symptom control, their disease progress assessment, as well as any sort of other questions they want to ask, and advanced care planning. Should it involve a solicitor? So people often have the misconception with advanced care planning that it needs to be, or some people have that misconception, it needs to be involving a legal professional, which it doesn't. And even with things like lasting a power of attorney, it doesn't necessarily need to involve specific legal advice. And I think it's important to highlight, certain faith groups and certain cultural groups may request specific support. So we certainly see that in certain patient groups in hospital, and we're often involving our chaplaincy team to support in advanced care planning and sealing of treatment discussions on occasions in patients with a strong religious faith. In terms of what we discuss, we've seen that kind of more general guidance from NHS England. These were some of the themes that came up in the work that I did from health professionals working with those with Parkinson's disease as key areas to address in Parkinson's disease. So that can be preferred priorities of care. So that's a more general element of what's important to the patient in the future. preferred place of care as their disease changes. So not necessarily preferred place of death at that stage, but where they want to be cared for at different points of disease. Who they might want to be involved in their care as their condition changes and how they might want them to be involved. Practical points around how they would manage specific elements of changing condition if they were to become, immobile, and how that might be approached. Things like clinically assisted nutrition, specifically around insertion of a peg or a rig. And we know that, evidence is not strong in that area for patients with Parkinson's or atypical Parkinson's disorders, whereas in some other neurological conditions, there's a wider body of evidence. So MND, for example. Might look at clinically assisted hydration, CPR decisions, preferred place of death. Limits to escalation of treatment, so whether the patient would want to be escalated to a high care environment, whether we feel as health professionals that's appropriate, whether they would want treatment of specific reversible causes, so things like infections, whether they would want antibiotic treatment, what level of treatment they would want, whether they would want intravenous treatment with antibiotics, whether they would want to come into hospital for that. And then people also suggested some of those more specific things we'll come on to in a moment. So the ADRTs, advanced decisions, using the tools to complete a more specific statement or advanced directive, appointment of a lasting power of attorney, and things like specific legally important things, so things like financial planning and wills. So going through some of these more specific elements, the advanced directive or living will, as it's sometimes called, this is your more kind of general statement of wishes or preferences. So it may not relate to a specific medical treatment. It's not legally binding as such, although depending on other documents that are in place, you may use this very closely to inform your best interest decision making in a patient where they lack capacity. There are lots of different formats that you can use for this. There are lots of different documents, a couple of which I'll show in a moment. But it may just be, a statement that the patient writes down. It may be something that, for example, a lot of patients I see in the MND clinic, I'll do a detailed section in their clinic letter around advanced care planning, what we've discussed. I'll ask them to look at that and correct any changes that they want to make when I see them the next time. And if you're doing it as a specific written advanced directive that the patient writes, you can't specifically demand any medical treatment that's not thought to be appropriate. So this is, a general statement of wishes of what's important to a patient, what they may or may not want, but it doesn't specify that you can't demand a particular medical treatment as part of this. Then we've got the very much more specific advanced decision to refuse treatment. So this refuses a specific treatment in a future time, at which time the patient lacks capacity. The key thing about this is it must be very specific to the circumstances that the patient is in at that time. It must be written, it must be signed and witnessed, and if it relates to a treatment which is potentially life-sustaining, you must document that you acknowledge that that life-sustaining treatment is being refused in this ADRT. It is legally binding with an asterisk in that it has to be specific to that particular situation. And for these ones, I think it is really important to have some sort of guidance from health professionals, because to be able to consider this without having the experience of knowing what patients may face in particular conditions, I think is a lot more difficult for people. Obviously, it should be made while somebody has capacity, and it should be carefully recorded and communicated as well. I have to say that I don't use ADRTs a lot in my clinical practice. I think the most common group is probably motor neuron disease around things like non-invasive ventilation, tracheostomies, but even in that group, it's not that common that I would use that because it has to relate so specifically to that second set of circumstances that I think more of a wider appreciation of patients' wishes is actually more practically useful at times, or having something like a lasting power of attorney in place. So coming on to that, lasting power of attorney, you can appoint anyone as your lasting power of attorney for health and welfare. So there are there are two types: health and welfare LPA versus financial LPA. Your health and welfare lasting power of attorney can refuse treatments on your behalf. Again, they can't demand treatments on your behalf that are considered medically inappropriate. You can appoint one person, or you can appoint a number of people, and you can appoint them to either act jointly or severally, so they may act independently of one another, or they may act together. If you do appoint a lasting power of attorney, it must be registered with the Office of the Public Guardian. And if you're on the other side of this as a health professional and someone says that their relative has appointed them as an LPA, if they don't have the documentation, you can make an urgent application to the office.
Sorry, everybody, we seem to have lost Tim in Salford. Ed, would you like to fill in?
Yeah, if we do some questions while Tim's frozen. Are we going to unfreeze him? You could thaw him out with some hair dryers while we do some questions. So there's a couple of questions. Well, there's one actually, but I've written some down. Do you use frailty scales to identify patients who may benefit from ACP discussions? I don't, to be honest. Frailty scores specifically is interesting, isn't it? That I haven't seen a lot about frailty scores in PD, and it's a conversation we've had at work in terms of whether it's an area to look at. I'm going to be a bit naughty as a geriatrician, so I think we may have reached the limit of frailty scores. I mean, we're really juicing that lemon, aren't we, at the moment? I think they're useful, but they're useful to a point. Parkinson's is, of course, a frailty syndrome, really, isn't it? It's a collection of frailty syndromes. And so I totally agree that having a frailty mindset is very useful for people with PD, even when they're much younger. I'm not aware of evidence using the frailty scores to screen for people with advanced care planning. And my feeling is they'd be too blunt. So we could use them as a red flag in our practice, couldn't we? We could say, you know, if people are getting CFS 5 and 6, is that then a time that we want to be thinking about this? But we've got more PD specific things that we could use. So HONINYAR-3. So HONINYAR-3 associated with step change in quality of life, axial rigidity, falls, recurrent falls, we know, and associated with progressive decline towards death. If we look at the Kempster study, it ties in with some of the features that Doug and Sue drew up in their palliative care sort of definition. So I think there would be better PD specific things which would kind of link with frailty scores rather than the frailty score per se. You could widen that conversation a little bit and say, could we use frailty scores to screen people who might benefit from palliative and supportive care? And I think there the answer is possibly. And so the PD hub in Hull does it? Am I going to tell fibs? Talked about using a frailty score as part of their screening in process. I don't think they are, but there are other general frailty hubs which do. So I think using a frailty score along with something else might be a useful way to screen a big cohort of people who are going to benefit from that wider umbrella of palliative and supportive care. And within that, you then have to use your own clinical skills to decide who would benefit from advanced care planning specifically, because of course that's going to be very person specific. It's a very long answer, but the hairdryers have worked and Tim's back, so we've thawed him out. I'm
really sorry about that. NHS Wi-Fi has failed me. I'm on my phone as a hotspot, so I hope this holds out. So I'll just pick up and carry on if that's okay. So the third document is around is a nice document for advice for healthcare professionals around advanced care planning, particularly related to patients in care homes. Actually, if we look at other Parkinson's specific information, some of you may have seen this from Parkinson's UK, preparing for end of life. So this is not just around, last days of life or last weeks of life. It goes through around lots of those other elements of advanced care planning that we've just touched on, and also about how you introduce those elements of discussion to those important to you, how you record those things, and the specific tools that you can use. There are a wide array of documents in use, and they can be quite area specific. So some of these, you may be familiar with this document on the right. The preferred priorities of care is perhaps the most widely used, more broad, advanced statement, and that talks about, you know, generally what's important to the person, and what's important to them in their life and their condition. It may talk about specific decisions, but it's certainly not an ADRT. We've got another document which looks at that. This is from the GSF website, Gold Standards Framework. As I said, they may be quite localized documents. So these, we've got 2 documents just in place in Salford, for example, and I know, you know, lots of the hospices may have their own locality documents talking about different elements of advanced care planning. The other one, which is becoming more widely used and perhaps more geographically widely used, is the respect form. So that gives an element of the patient's wishes. It also takes you through some of the medical decision making. It can include things like resuscitation status. There's kind of an analog scale where a patient can rate what they feel about how aggressively they would want to be treated, from, you know, not very aggressively, not a lot of invasive tests or investigations, up to absolutely treat anything that you possibly can, treat all reversible causes, and investigate anything that you feel is appropriate. So that's probably going to become more widely used, I think. And then we've got things like obviously the do not resuscitate decision-making documentation, which again, this is the Northwest Ambulance one, Northwest one, which our ambulance services are familiar with, but which may vary area to area. I think the other thing that I wanted to flag was, again, you may be familiar with this, for patients who are known to palliative care services, who are felt to be in the last year of life, they may often have what we call an EPACS record, so an electronic palliative care coordination system, and this should be either in place or in development in most areas of the country, I think, to a variable level. So this enables an electronic record to be made of advanced care planning, and there is a kind of standard data set of things that have to be included on that. But the most important thing is that, for me, doing this is the free text box where you can just go into the patient's wishes. And for our system in Salford, it's called Communicate My Care. It was called Coordinate My Care, but that was then copyrighted by the team who developed that in London, which I'll come into in a moment. And so our hospital EPR system, if we put something on, it will communicate that in real time to the ambulance service, to district nurses. It's available on the district nursing system. It should be available on the GP system, and then it can be uploaded to our systems as well. So I think it's really important, if we do any element of advanced care planning, regardless of condition, you know, Parkinson's, neurological conditions or otherwise, if we don't then communicate that, it's essentially not going to work. So this is one way in which it can work. And I guess if we're completely honest, this doesn't always work seamlessly, but communicating it in some form and making sure that patients' relatives particularly are aware, if you've got a paper document that they can take to different care settings, I think is really key. We know that if people do have an advanced care planning record done by this format, so this is from the London Coordinate My Care system, which is a lot more developed system, I get the impression. If they have had the Coordinate My Care record completed, they are significantly more likely to die in their own home or a care home, and significantly less likely to die than the national figures in patients who don't necessarily have a similar electronic advanced care planning record. And so, yeah, this is, again, looking at one of the studies they did looking at Communicate My Care in London, and you can see that the home was the most common place of death. When we think about those national figures around hospital, you know, significantly fewer numbers dying in hospital to that over 40% national figure. So yeah, within another study, they looked at other evidence around Coordinate My Care. 77% of people died in their chosen location who had a Coordinate My Care record. Most of the people who had a record stated a preference they would like to die at home, in a care home or in a hospice, so bears out that information from earlier about not wanting to die in a hospital setting. When first preference of place of death was achieved. 74% that happened when they chose home, nearly 90% when it was a care home, and then a smaller number, but still significant in a hospice. And I wonder if some of that is in relation to, being able to admit people in a timely way to hospice. Sometimes we can't always guarantee that we have a bed available when people are approaching the last days, although if that's their choice, obviously we would aim to facilitate that. Then in terms of coming to the how of advanced care planning, I guess this is quite variable. These are just some of the things that I think are important in successful advanced care planning discussion. And I think this is, valid to all conditions. A lot of it is common sense and is good communication skills. So finding that time, planning the discussion, allowing time as far as you can in a hospital environment, having a kind of quiet, calm place. It's not always possible, but trying to facilitate that if you can. Absolutely maximising the capacity of the patient to engage in these sorts of discussions. So obviously patients who have hearing impairment, making sure they've got the hearing aid in, making sure that they're not in pain or have other significant symptoms at the time when you're trying to have a discussion. I think it's key to begin advanced care planning not with diving in around specific elements which there may be pressure on from a medical perspective to make decisions on, but to start with the patient's own understanding about their condition, framing the discussion effectively, and explaining why you're having this discussion at this particular time. I always, ask patients permission to start talking about advanced care planning, acknowledging that it can be a distressing area and that we would never force anyone to have discussions about something that they don't want to. And often if patients are unsure at that stage, I will say to them, well, is it okay if I start to talk about some of the areas we could consider? If you want to talk about those in more detail, we will do that. If it's something you really don't want to talk about, that's absolutely fine. And if we do go into detail, if you want to stop at any point, again, that's absolutely fine. There's no pressure. I think it's important to kind of develop your own approach to this, an introduction that you're comfortable with. But at the same time, it really has to be, that very individualized process according to the patient that you're talking to in terms of their background, in terms of their disease status, in terms of their wishes. And obviously it has to be done in a kind of compassionate, empathic way, regardless of the time or the patient's condition. So yeah, really important to kind of check with patients they've understood, check and chunk that information. I think it's easy to overload with patients with lots of advanced care planning discussions and information and choices at one time for them to feel a bit kind of bewildered about that. So, it's a process of development. It's something that you can come back to. It's not something you should feel forced to do all in one go. Really important to respond to patient cues. They may want to focus on a particular element of advanced care planning that we don't think is significant at all from our previous experience of them. We have lots of patients where we've gone in to talk about nutrition and hydration and they've wanted to talk about who's going to care for their cat. So it's really important to respond to their cues, and including cues that they may not want to continue the discussion, obviously. At the end, really important to summarise, check their understanding, to document that information in some form, either with one of those tools or with a more broad statement, or if you're in the clinic setting, maybe having that specific paragraph or heading in the letter around advanced care planning. And then once you've done it, absolutely to seek their permission to share that information, either through one of the advanced care planning records or some other form, even if it's through the letter going to the GP, everybody else involved in care, and the patient having their own copy of that. And yeah, it's not set in stone. Choices can change. People can change their opinions. People can change their minds. So planning for a review around advanced care planning or giving the patient that information of how they would do that is important as well, I think. So those are kind of the main areas I wanted to cover in terms of advanced care planning. As I said, I'd be really interested in your experiences. Just to kind of plug palliative care, I think it's still in Parkinson's disease not fully incorporated, perhaps more so in MSA and PSP and people with more advanced disease or rapidly changing conditions. There isn't kind of very specific evidence on how you involve palliative care. And I noticed some of the discussions you had when I came back on, there are probably specific things that we can use as pointers, and some of those gold standard framework indicators might help with that. But I think that's, probably an area for future research. Thanks very much for listening. So yeah, as I said, it'd be really important, really interesting to have your thoughts on how you approach advanced care planning yourselves and this patient group.
Thanks, Tim. That was awesome. You navigated the technical difficulties very well as well. So thank you for that. We have got some interesting questions. Do send your questions in. We've probably got a little bit of time to answer them. So in the question box, we've got, is advanced care planning in Parkinson's an area for research? Don't know what you think about that.
Yeah, absolutely. So I think, there has been more research in the last few years. When I started my research project as a registrar, there was very little looking at either patient or health professionals' approach to advanced care planning. And really we had the kind of more broad guidance documents around what we should cover in advanced care planning. So a lot more has come out, and it's interesting to read that systematic review that I referred to in more detail. That gives some quite gives quite good evidence overview. But yeah, absolutely, I think there's still more to be done. So in relation to when you involve specialist palliative care, perhaps as well as advanced care planning.
Yeah, and there's always more to do, isn't there? I think in the UK we're increasingly falling behind the States in terms of how much they're doing, and so I think we probably have got more to do. There's a danger, I think, that we get quite led by evidence and practice and research from the States and then apply it here. And I think particularly for neurological conditions where it's such a different setting in terms of the intensity of intervention which you're going to get if you don't advance care plan, and the culture and the religiosity often around some of these things. I think we probably do need to have UK specific data rather than just being led by American data, perhaps. And then it's a couple of really interesting ones up here. So Mel Falk says, it can be difficult, particularly in a sort of urgent or emergent situation, for people to help decide sort of what they'd want when they haven't got experience of that. And I think that's very pertinent, isn't it? And probably touched on a wider point of whether or not people can project forward to their future selves. And when you're physically robust, it is very easy to be a bit, you can make slightly snapshot statements about what you would or wouldn't want. And when people become frailer, I'm sure the people in the audience will recognize this, that when people become frailer, often people are more accepting of states that they previously would not have wanted. I don't know what you think.
I think that's a really interesting point around, 80% of people saying that they want to die in their own homes. Frequently we see when people encounter those more difficult symptom control scenarios or support scenarios, that often changes in all disease groups, I think, particularly cancer patients where you may be struggling with symptoms.
How do you deal with that issue of if you're taking someone through an advanced care planning process, how do you deal with that aspect of helping them to consider what might be acceptable later on, even, or to envisage what they might be like, to take themselves into that future scenario?
I think for me at least, it's about just being really honest with them about services that are available and what can look like in different settings when you're talking about end of life care. So I think it's helpful just to think about practically what's available in the community. If someone's wanting to die at home, they may get visits from district nurses or carers 3 or 4 times a day max, but they're not going to have somebody there, a healthcare professional there with them all of the time. They may have gaps in symptom control if they need additional medications overnight. There may be delays in that, versus thinking about hospice setting where they've got more specialist care, they've got symptom control medication there all of the time, or even the hospice setting always being there as a kind of backstop where people will have that kind of 24-hour support and it's, you know, sometimes seen as a failure. I think, you know, there's lots of pressure around admission avoidance, but actually hospital is sometimes the right place for people to be.
Definitely. Yeah, I can think for someone who I think sometimes it's been helpful to go into what do you mean by this? You know, people say, oh, you know, if I get dependent, or if I, you know, these sorts of things, I wouldn't want, you know, I'd want life prolonging therapy if I was still going to be independent, but not if I was dependent. And, you know, what do you actually mean by that? So I can think of someone where we spent quite a long time trying to unpack that and saying, you know, what is it that you're worried about? What is it that wouldn't be acceptable to you? What level of dependency? Because there are different levels of dependency. And when we unpacked it and spent some time digging into it, it was the idea of being sort of washed in bed and cared for in bed, not being able to get out of bed. That was kind of this tipping point for this person as to what would be acceptable. So it was like, so we ended up saying that she would want life prolonging therapy if it was felt that she had a reasonable chance of returning to, you know, a level before that. But if it was likely that she'd be left in a level where she was going to be nursed in bed, then that wouldn't be acceptable to her. But even then, I have to say I'm quite wary of this idea of how you reinforce that and how you account for people's changing views as they become more dependent, as they experience the impact of Parkinson's or another disease, that their idea of acceptability might change. And I think that building in that aspect of revisiting care plans and
yeah, I think that's really important,
isn't it?
Yeah.
Sorry, that was a waffle from me, but I think it's a really interesting point, actually. There's a couple more down here. So Sam Cohen, thank you for your question, says, it's a bit long, so I'm trying to paraphrase it. Essentially, we're talking about damaging the therapeutic relationship, and that sometimes people don't do advanced care planning for that reason. So do we think it should be the main physician or specialist nurse who deals with that? Do you think it damages the working doctor-patient relationship?
It depends on, you know, how it's framed, really, doesn't it? Would be my thought on that. You know, advanced care planning is not about saying we're not going to do anything. It's about saying, you know, what is important to you are the things that you don't want us to do. Do you want us to do everything that we would offer? And I think, you know, if it's framed in the right way, it needn't damage that relationship. I think, honestly, it can be anyone who feels comfortable with that discussion.
It can strengthen the relationship, can't it? Like, errors of omission and errors of commission, right? So, you know, yes, we're all scared about an error of commission, but what about the errors of omission and the people who are sitting there thinking, my God, I wish they'd asked me this? Or why the heck doesn't my doctor respond when I give him this cue? You know, the long sigh and the, you know, oh, so what happened? Yeah, I wonder what happens next as they leave the room. You know, it's dropped in there for a reason. And so I think, so yeah, I think there are risks in both directions, actually, in terms of therapeutic relationship. In terms of who should trigger it, so I haven't seen data on this from the UK. Maybe there's something in that paper you mentioned. In the States, there's people were pretty spread about whether they thought it should be their GP or their neurologist, stroke geriatrician, or the patient who triggered it. So I don't think we can be too prescriptive about that. I think certainly we shouldn't say it should only come from the patient or it should only come from the doctor. And I don't think it does, from my own experience, and correct me if you disagree, but I don't think it does need to be their main doctor or nurse. So in my own practice, we have this sort of longer clinic which I run, and which some of my neurology colleagues would refer into specifically. So it gives them the ability to recognize that verbal or non-verbal cue, say, I've heard you, we haven't got time to do it today, this person can do it with you. And I think actually that's quite beneficial. And sometimes people would be referred into that clinic without their primary person knowing, as that's the one thing I do stipulate, is it needs to come, you know, go back via them and check they're happy. But I've never had anyone not be happy about us doing that with or for their patients. Sorry, we're skipping through. Oh, there's a couple of just messages in there rather than questions. Any other questions that I've missed? I think we've got all of them. Is there one coming through? No, I don't think so.
around the legally binding nature.
Oh, have I missed that? Oh, thank you. Yeah, go on, you can take that then. Sorry.
So yeah, I mean, obviously the ADRTs strictly should be legally binding if they are specific enough, but I don't think you can ever plan for every situation, which is why they're not perhaps something that I would use that often. And even the other thing is, so lasting power of attorney, theoretically, you can refuse any treatment on behalf of whoever's appointed that for you. But if actually that's considered a very unwise or not in the patient's best interest, that can still be challenged by clinicians and go through various processes, mediation, ultimately to the court of protection. So that, these things can all be challenged. And I suppose even if a patient's advanced care planning wishes are recorded in some form and it's not felt to be, for whatever reason, in their best interest at that time, you're not kind of necessarily bound to follow those things, which can be tricky, because then it gets to the point of, well, actually, if we're not going to follow these things, why do we ask patients about them? So hopefully, in the majority of situations, it should be followed. But yeah, it's not cast iron, I don't think, in a legal sense.
I think that's what I tend to do statements of wishes and preferences, and I find them really useful for that reason, because you can be slightly broader and you haven't got to pre-imagine every situation. And I find that means that people try really actively, clinicians, to apply those to their decision making. Whereas in the few cases where I've come across ADRTs, I haven't actually made one myself, but it's almost like people are finding reasons not to use them. Like they're going, oh, but this says you wouldn't want to be intubated on a Tuesday, but now it's Wednesday, and would you? They're almost like trying to unpick it, and it feels sometimes it's felt as though it forces people to come at it the wrong way. They're trying to go, is this still valid, rather than saying, I've got this thing, let's try and apply it. And I think that's not, patients wouldn't realise that. And because it frightens people to have a legally binding situation, doesn't it, I think, especially in an emergency.
Yeah. There's one other kind of, I think it's an excellent point actually from Melanie Falk, is it? I like to talk to patients about the best way to continue living well rather than just focus on dying. This is something I use a lot actually, particularly in clinic. I frame it by saying, obviously our focus is on helping you maintain the best possible quality of life that you can have for as long as possible, but there are these areas that might be useful to consider. So I think that's a really good point actually. Focusing on the positive side, not just making about death and dying.
Yes. Do you practically come back and revisit these things? I don't think I've formally gone back and revisited any of the advanced care plans that I've made. And in conversations, particularly with palliative care specialists, I've thought I really ought to do that. And it's going to be quite difficult practically to do it.
For clinic patients, I might do that, but for where it's those patients where I kind of maybe dip in and dip out in the hospital and not see them again, it's difficult to do, isn't it? And I suppose it's then left to community services. So I wouldn't necessarily always do that, if I'm being honest.
And we've got another question. Should the clinician managing the patient with PD be involved in the palliative care? So I suppose it depends what you mean by palliative care, doesn't it? Palliative approach care, yes, because we should be doing it anyway. Specialist palliative care, we're going to send, hopefully make specific referrals to people like Tim for things like that, for specific issues.
Yeah, I think it's a good point, isn't it? Because the majority of palliative care that's done is generalist palliative care, mostly by GPs, community services. There's only actually a small number of patients that get to specialist palliative care. And in terms of who you refer to that, as we've talked about, there's not strong evidence in Parkinson's disease. I would tend to say any patient where you feel that they have a need that for whatever reason you can't meet or can't be met in another setting, palliative care should be there. Specialist palliative care should be there to support.
I think even with our specialist palliative care colleagues, I think there's a symbiotic relationship. I mean, certainly people in the hospice, if they're not haven't got an interest in neurological disease, PD can be quite intimidating. It's a range of drugs which people aren't used to managing. People are worried about folks with PDD and DLB having sort of behavioural issues. So I probably get 2 or 3 phone calls a week, either from the community or from specialist palliative care colleagues about patients. and you have a conversation, and also because it's a bit of an evidence-free zone often, isn't it? So it's the right thing to do to share the decision-making burden, I think. I think, how are we doing for time, Daiga? I think Tim had to run off and collect children from somewhere at 5.
We've got 2 more questions, I think, and then we can go. So there's one from Julia and one from Bijo.
Who'll do the advanced care plan, the GP or the consultant? I don't think you can be. I don't think you can answer that. I think it's whoever's appropriate for that person at that time, who's got the time to do it. I think Tim covered that really well.
Yeah, absolutely.
And then talking about starting from a research base, mentioned brain donation, which can lead nicely to other end of life options. Yeah, it's not something it hasn't been my approach, but I guess people with PD will sometimes come and I think the thing is being responsive, isn't it? And using your communication skills and being responsive to what people are saying. And sometimes people come in, don't they, and say, I want to be useful after I die, and and how can you help me? And as you say, that would be a good link into it, wouldn't it? I can't say I ever talk to people about brain donation. Maybe I should.
I haven't done that either.
Brilliant. Thank you very much, both. I think that rounds it all up nicely. Tim can go and collect his children. Ed can take his gilet off. We can all go and have a nice cup of tea. That was really, really interesting. And more than 100 of you stayed to the very end. So thank you very much for that. And we'll see you again soon on the next webinar. Thank you, Ed and Tim. Bye.
Thanks, guys. I never take my gilet out on a Wednesday, Daiga.
Okay, good to know.
Thanks.